Usually when we talk about a medical diagnosis, there's this expectation of like absolute precision. You break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, well, there's the problem.
Right. It's highly visible. It's binary, broken or not broken. We just naturally gravitate toward that kind of clean, comforting categorization when it comes to our health.
We really do. But today, we are cracking open a medical textbook specifically, excerpts from Clinical Management of Sexually Transmitted and Reproductive Tract Infections by Cheryl L. Kovar.
It's a fantastic resource.
It is, and we are going to use it to map out a battlefield that completely defies that simple logic. When it comes to sexual and reproductive health, that diagnostic X-ray machine is pretty much useless.
Yeah, completely useless. You are looking at a landscape that is mostly invisible, incredibly patient, and just highly complex.
Welcome to the deep dive. Our mission today is to translate the dense clinical jargon of these infections into a practical, eye-opening guide. Whether you are prepping for a medical career, managing your own health, or just insanely curious about the invisible ecosystems living in and on us, we're going to arm you with the facts and dispel the myths.
That's the goal.
Okay, let's unpack this. Before we zoom in on the specific microscopic invaders, we really need to understand the battlefield itself.
What's fascinating here is how much our understanding of these ancient human afflictions has evolved, especially in terms of prevention and the sheer economic scale of the issue.
The numbers from the text are staggering. STIs cost society $16 billion annually as of 2018.
16 billion, just let that sink in.
Right. And in that same year, there were 26 million new cases in America alone.
And if you dig into the demographics of those 26 million new infections, a really crucial pattern emerges. Half of those are in the 15 to 24 age group.
Wow. That is a massive concentration in a very specific, highly active window of life.
Exactly. So if you are a clinician facing those statistics, how do you even begin to screen a patient for that kind of risk? You can't just guess based on how someone looks in the waiting room.
You definitely can't. So how do they actually do it?
Well, clinicians rely on a structured framework known as the 5 Ps to take a sexual history. It stands for partners, practices, protection.
Okay, wait. So partners, practices, protection, what are the last two?
Past history and pregnancy intention. But it's not just a checklist, it's a dynamic risk assessment.
I see. So it's like a personalized risk assessment algorithm that doctors just run in their heads.
Precisely. By asking about practices, for example, they aren't just being nosy. They are trying to map out your specific biological exposure profile.
Right, to figure out exactly which anatomical sites might actually need screening.
Exactly. It individualizes the prevention counseling. But identifying the risk profile is really only the first hurdle. The actual logistics of treatment bring a whole new set of barriers.
Which brings us to EPT, right? Expedited partner therapy. I found this concept in the text so clever.
It's a game changer.
So, if a patient tests positive for something highly transmissible, the clinician can write a prescription not just for the patient, but directly for their partner.
Yep. So the partner doesn't even have to come into the clinic.
Which completely circumvents the stigma or like the logistical hurdles of treatment.
It's a vital harm reduction strategy. You are treating the ecosystem of the relationship, not just the individual.
But, that assumes a cooperative ecosystem. I was reading this and pushing back a bit on the standard public health advice we always hear, which is just use condoms.
Right, the classic advice.
But what happens when the patient isn't in a safe dynamic to negotiate that?
That is such an important point. And it brings up what the clinical guidelines call reproductive coercion.
Which is terrifying.
It really is. It's when a partner refuses to use a condom or actively sabotages birth control. It directly interferes with a woman's ability to protect her own health.
So the biological risk is entirely dictated by a toxic social dynamic.
Exactly. And this is why non-judgmental nursing and reproductive coercion screening are so heavily emphasized now. You have to address the social environment because it's the actual vector for the disease.
Okay, so once the provider assesses that behavioral risk, what exactly are they hunting for? Let's transition from the behavioral stuff to the actual bacterial pathogens.
The heavyweights.
Right. And they are terrifying, specifically because they are so quiet.
They are absolute masters of stealth. Let's look at chlamydia. It's the most common notifiable STI, hovering around 1.8 million cases in 2019.
And it is highly destructive, but often completely asymptomatic.
Right. You feel totally fine. But if left untreated, 10 to 15% of women develop pelvic inflammatory disease, or PID.
So what does this all mean? I compare these bacteria to termites in the walls.
Oh, that's a perfect analogy.
You feel totally fine, your house looks great, while they are secretly compromising the structural integrity of your reproductive system.
Precisely. That PID can lead to severe chronic pain, ectopic pregnancies, and outright infertility. The damage accrues over time without you even knowing it.
Which is just wild. And then we have gonorrhea.
Yes, and cases of gonorrhea have spiked 92% since 2009.
92%.
Yeah. But the terrifying fact isn't just the volume, it's that more than half of these infections are resistant to at least one antibiotic.
Wow. So the bacteria are actually outsmarting the drugs.
They are. It now requires a massive, heavy-duty 500 milligram intramuscular dose of ceftriaxone to cure it.
An injection, not just a pill anymore.
Right. And because of this resistance, providers often use directly observed therapy.
Which means making the patient take the meds right in front of them to ensure compliance, right?
Exactly. You cannot risk a patient missing a dose and giving the bacteria a chance to mutate further.
Okay, and rounding out the bacterial heavyweights is syphilis.
Syphilis is a highly complex disease. It operates in distinct stages.
It starts with that painless chancre, right?
Yes, a painless sore at the site of entry. And because it doesn't hurt, people often ignore it. Then it moves to a secondary stage.
Which involves a rash or those wart-like lesions called condylomata lata.
You got it. And if it's still untreated, it pulls its most dangerous trick. It goes into a latent phase.
It just disappears.
It drops off the radar entirely. But it's secretly destroying multiple organ systems from the inside out.
It's like a sleeper cell.
Yeah.
So as intense as these bacterial infections are, they are like stealthy termites that can be exterminated with antibiotics if we catch them.
Right, they are curable.
But when we look at viruses, they play a completely different lifelong game. We are shifting from curable infections to manageable ones.
Viral STIs are a totally different beast. Take HPV, human papillomavirus. It is the most common viral STI, affecting around 43 million Americans.
43 million. That is a huge portion of the population.
It is. And the text notes there are about 150 types of HPV.
But they don't all do the same thing, do they?
No, not at all. You have types 6 and 11, which cause genital warts. But then you have types 16 and 18, which are highly oncogenic.
Meaning they cause cancer.
Exactly. Primarily cervical cancer, but others as well.
Here's where it gets really interesting. I was looking at the irony of the immune system here. With HPV, a healthy young immune system often just clears the virus completely on its own.
It does. Most people clear it within 2 years.
But if it doesn't, we have the Gardasil 9 vaccine, which prevents the most dangerous strains. And the text mentions it's now approved for adults up to age 45.
That is a massive public health win. It's primary prevention at its best. Now, another prevalent virus is HSV, the herpes simplex virus.
Right, HSV1 and HSV2.
Yeah. And the crucial thing the text notes here is that many people are completely asymptomatic, but they still shed and transmit the virus.
So they don't even have visible outbreak, but they are contagious.
Precisely, asymptomatic shedding. And for those who do get outbreaks, they can be triggered by stress, menstruation, or incredibly even UV light.
UV light. Like just being out in the sun can trigger a herpes outbreak.
Yeah, physical stress to the body can wake the dormant virus.
That is wild. Okay, so HPV and HSV evade the immune system, but with HIV, the virus actually targets and destroys the immune system, right? Specifically, those CD4 T cells.
Yes, it goes straight for the command center. And it's important to note that women make up 23% of HIV cases. It's not just a disease of men who have sex with men.
But the text really highlights the profound success of ART, antiretroviral therapy.
RT is miraculous. It can suppress the virus to undetectable levels.
And undetectable means untransmittable, zero risk of transmission to a partner.
Exactly, 0. Also, the perinatal transmission, meaning mother to child, drops to less than 2% when the mother is on RT.
And for prevention, we have pre-exposure prophylaxis, pre-UP, and post-exposure prophylaxis, PEP. These are absolute game changers.
They really are. We have the tools to chemically block the virus.
Okay, so we've spent all this time talking about external invaders transmitted by partners. But what happens when the body's own internal ecosystem gets thrown out of whack?
Right.
Even without a partner.
Right, we have to talk about the vaginal environment.
I compare the vagina to a complex rainforest ecosystem, or like a self-cleaning oven.
Both are great ways to visualize it. Normal vaginal secretions are highly regulated. They are acidic, with a pH of 3.8 to 4.5, and full of healthy lactobacilli.
The good bacteria.
Yes, they actively maintain that acidic environment to keep everything else in check.
But when that balance shifts, you get bacterial vaginosis, or BV, which is the most common vaginal symptom.
In BV, those good lactobacilli are replaced by anaerobic bacteria. The pH rises above 4.5.
And how do clinicians diagnose that? I remember reading about a very specific test.
Yes, the whiff test.
The whiff test.
Yeah, they add a drop of potassium hydroxide to the sample, and if BV is present, it releases a very distinct, fishy odor. They also look under a microscope for clue cells, which are native cells covered in the invading bacteria.
Okay, so that's BV. But then we have candidiasis, or a yeast infection. The text says 75% of women will get this.
It's incredibly common, but unlike BV with a yeast infection, the pH actually stays normal.
Really? So what causes the yeast to overgrow?
It's often caused by things that disrupt the local environment without changing the pH. Taking broad-spectrum antibiotics, wearing tight, non-breathable clothing, or even a high-sugar diet.
So when you introduce broad-spectrum antibiotics, it's like clear-cutting the rainforest. You kill the good lactobacilli, allowing the weeds, the yeast, to just completely take over.
That's exactly the mechanism. Now, we should also mention trichomoniasis.
Right, which is different because it's actually an STI, not just an imbalance.
Yes, it's a non-viral protozoan STI. It's highly symptomatic, usually causing a frothy discharge.
And it causes those characteristic strawberry spots on the cervix, right?
Yes, tiny microhemorrhages that the clinician can actually see.
Okay, before we move on, we have to talk about the danger of douching.
Oh, absolutely. The text is very clear on this.
It notes that douching increases the risk of PID by 24% because you are artificially flushing out that healthy flora and disrupting the self-cleaning oven.
It's one of the worst things you can do for that ecosystem.
Okay, so all the pathogens we've discussed so far are dangerous to an adult. But what happens when we introduce a developing fetus into the equation?
The stakes multiply exponentially.
Because the biological barriers change.
Exactly. In obstetrics, we look very closely at the TORCH infections.
TORCH, T-O-R-C-H. What does that stand for?
It stands for toxoplasmosis, other infections like hepatitis, rubella, cytomegalovirus, and herpes simplex virus.
And why are these specific ones grouped together?
Because they are unique in their ability to cross the placenta. Most infections don't reach the baby until delivery, but TORCH pathogens can infect the fetus directly in utero.
Let's talk about toxoplasmosis. You can catch this from raw meat or, famously, cat litter.
Right, and it's often completely asymptomatic in the mother. She might feel totally fine.
Wait, so a mother might just think she has a mild flu-like, zero major alarms going off for her own health, but for the fetus, it's a devastating event.
If we connect this to the bigger picture, it explains why prenatal screening is so aggressive. Because, yes, for the fetus, especially in the first trimester, toxoplasmosis causes catastrophic neurological damage.
That is terrifying. And rubella is similar, right?
Yes, rubella can cause profound congenital defects, deafness, cataracts, cardiac defects.
But you can't just give a pregnant woman the rubella vaccine if she's not immune, can you?
No, you cannot. The vaccine is a live attenuated virus, so it is strictly contraindicated during pregnancy.
So she just has to avoid exposure entirely for 9 months.
Yes, and then she must wait until the postpartum period to get vaccinated to protect her future pregnancies.
Wow. It just really highlights how incredibly vulnerable that fetal ecosystem is.
It requires extreme vigilance.
So, to you, our listener, what is the major takeaway from all of this? We've seen today that reproductive health isn't just about avoiding bad choices. It is about actively managing a highly complex, vulnerable ecosystem.
It's about being proactive, not just reactive.
Exactly. By knowing the 5 Ps, by understanding the fundamental difference between bacterial termites and viral hijackers, and by respecting your body's natural flora, you are empowered to actually take control of your health.
Knowledge is your best defense.
Absolutely. And as we wrap up, I want to leave you with a final thought to ponder that builds on what we read in the text today.
Okay, what is it?
Well, we learned that over half of all gonorrhea infections are now resistant to at least one antibiotic. Clinics are currently forced to rely on a single, heavy-duty injectable drug, ceftriaxone, to stop it.
Which is an alarming bottleneck.
It really is. So as these ancient bacteria continue to swap genetic code and outsmart our modern medicines, what happens when that final drug stops working?
That is the million-dollar question in public health right now.
Are we heading toward a future where curable bacterial STIs become permanent, untradeable conditions once again? It's a microscopic arms race, and it is happening right now, inside millions of people. Think about that the next time you hear someone say, oh, it's just a bacterial infection. Thanks for joining us on this deep dive.